This is primarily, my apologies to all the senior people who are there because they would be knowing much of it. This I thought was a revision for all the DNB and DM candidates, okay? So others are most welcome to give their comments. This is a very common knowledge that when somebody comes to us with reflux-like symptoms, we first think of giving them a PPI test. And I think last time there was this gentleman who was doing a thesis on GERD. What's his name? Last time he answered all the questions.
He's here only, sir.
What's his name?
Karthik.
So Karthik, for you, it's a bit of a repetition, but I think that, you answered extremely well. I just thought that, we need to share those same facts and figures with everybody there so that we are on the same page. So what we do is something called a PPI test, and we all do it in our own ways. So I thought that it's good for us to know how the test was started and what are the exact implications, okay? So usually it indicates using a double dose PPI twice a day for 14 days. That is the original description. And the PPI test was actually described with esomeprazole. But that apart, now it is expanded to almost anyone. And that is something which we clinically all do. Sometimes we give a little lower dose, whatever. So the question that could be asked in a DNB exam is that, okay, you have given the PPI, what is the sensitivity and specificity of this test? In day-to-day clinical practice, we don't follow so much, but if somebody asks you, so these have been studies which have been done. So the sensitivity is about 50 to 70%, so 2/3, and the specificity is only 40%. And that is the reason why many people, when they come back to you in the clinic, you are a little confused if the response has not been that dramatic. So if it has been very dramatic, no questions asked, okay? So now suppose somebody comes back and he tells you that I haven't really got that much amount of response. We need to obviously ask certain questions. And the usual question that comes in clinical practice is, you have given a reasonable good dose of PPI, you believe it is reflux, then why is he still having some symptoms? Of course, you have to make sure that the symptoms pertain to the same problem, that is heartburn. So these are the two things that I thought we need to know. If you have persistent symptoms, it could either be a refractory GERD or a functional heartburn. And usually what we think is that as clinicians, when we are very busy, we usually lump both of them together. And nowadays, because of PPI sponsorship, so there are a whole lot of seminars, talks and everything on refractory GERD, which basically means that you go on increasing the amount of acid suppression because apparently it is the acid which is always causing the problem. Okay? Please stop me whenever you want, okay? But one has to keep in mind that refractory GERD is actually not that common. And there is this other element called functional heartburn. And it is very important to be cognizant of it because usually what I have seen in practice also is that suppose a colleague of mine has given esomeprazole and another colleague has then after that he's not got response. So somebody has changed it to rabiprazole, then somebody to pantoprazole. So everybody is repeating the same PPIs, but the person is not always getting better. Okay. So there now we must think a little differently that it may not be refractory GERD, but it could be functional heartburn. Now, in principle, we need to understand what is the difference between the two. So in principle, by the way, the Diamond study is a very important study. So I think people must remember that name, Diamond study, okay, done quite some time back, 2012, and there are many subsets to it. So especially for DNB and DM candidates, it's important. So refractory GERD means that actually GERD is still taking place. So your medicines have not been able to control it. And there can be actually two reasons for it. usually the fact that there is more acid than what your PPI is able to control is really hardly the case. It usually doesn't occur unless you have very bad diseases like Zollinger-Ellison syndrome or something like that. But some degree of reflux can occur in which it is not heartburn always, but other manifestations due to non-acid reflux. That's possibility, but it is reflux related. So if you do something else, like say if you are looking at, say for example, a pH metry, or a pH metry wouldn't be the best test, an impedance test, you would find that people who have refractory GERD, they have a positive impedance test. Okay, but suppose now the person's symptoms are persisting and your impedance test shows that it is negative, and he's still complaining of very GERD-like symptoms, then that actually qualifies for the other diagnosis, which is actually given this other name called functional heartburn. So functional heartburn is something like irritable bowel syndrome, where it is a functional disorder. And no matter what you do, any adequate amount of acid suppression is not really going to be helpful. Okay. And here again, there is no such thing as impaired mucosal barrier or anything of that type, because functional, and there is in fact no reflux. So that's why your sensitive receptors and all doesn't apply for functional heartburn. Whereas for refractory heartburn, they all apply. So I thought that we just need to make that little distinction in our minds, what we are talking about. And what Rome 4 has done, I'm sure all of you have gone through it, but it would be good for all of you to go through it again in great detail, is that they have now classified functional gastrointestinal disorders into a huge number of groups. So earlier on, it used to be only IBS, then it became, functional constipation and IBS. But now you see, the number of disorders which come under functional is huge. So we must ask some of our examiners, potential examiners, Dr. Palniswamy and Jayanti and all that. Is it necessary for everybody to know all of them and to know the definition of each and every one of them? It may be very difficult. I personally find it very difficult, because if you look at it, there are 6 domains and you have 27 disorders. So there are specific disorders of 19 types and subcategories of 14 types. So let me go back to the last slide, and that's why I thought it's very important that how far a DNB student is expected to know. So it's a bit difficult to read, but functional bowel disorders now comes under esophageal disorders. There are 5 of them. Gastroduodenal disorders, we know quite a few of them, like functional dyspepsias and so on and so forth. Then bowel disorders, so there are 6 of them, out of which we are familiar with one, that is irritable bowel syndrome, and to some extent functional constipation, but there are quite a few. So in the functional group, now you have a centrally mediated disorders of gastrointestinal pain. So functional abdominal pain. I think the pediatricians use it quite frequently. Then the 5th one is gallbladder and sphincter of Oddi disorders. And the last is anorectal disorders. So anorectal, for example, we thought of fecal incontinence and functional anorectal pain. But if you remember, we knew only 1 or 2, and the lists have really expanded. And if you have a difficult examiner, he might actually ask you, like, what is the difference between functional defecation disorders of inadequate defecatory propulsion versus dyssynergic defecation? Now, for most of us who are not doing research, it probably doesn't matter. But the complexity of understanding is getting very deep, mainly because one needs to try and apply different methods of understanding the mechanisms through investigations and or treatment which becomes available. So at least I would expect you to know the domains and know some of the prominent disorders. And you may or may not remember the 27 of them, but that is, I think we must ask Jayanti what she would want. So of the functional GI disorders, Rome 4, I have put a few which I thought are the ones which we are familiar with, but you have to now expand your canvas. So in functional, you have got a functional chest pain, a functional heartburn. I was just talking about that. Reflux hypersensitivity. So this is the area where reflux does occur, but for small amounts of reflux, which are almost like normal, the person is very hypersensitive. So they have done studies of putting balloons in the esophagus, and even with very mild distension, this person will howl with pain, which means that the neural receptors at the end organ are hypersensitive. Globus, we all know, it's a feeling of stickiness up there in the throat. And functional dysphagia, another term which has come. In the gastroduodenal, again, thanks to the new molecules which are being marketed and a whole lot of CMEs which are occurring, we have learned a bit about PP distress syndrome, postprandial distress syndrome, and epigastric pain syndrome. But that we will discuss some other time, not today. But remember, that's within dyspepsia. And then there is something which comes as belching disorders. So if we now have a patient with aerophagia, which we very commonly see, we know that it's got stress relationship and all that. So that comes as B2, that's gastroduodenal disorder, belching disorder. And then of course you have got in the bowel disorders, IBS, and quite a few others which you can read up. Now, I'll go a little far and I'll talk to you about the fact that what is so unique about functional bowel disorders is that actually they are not true to type. So any person with one part of the organ being involved with a functional disorder can actually have a good bit of overlapping syndrome with symptoms with another. Why I'm mentioning it is because when the person comes back, it's very common that, you are treating him for one set of symptoms. He comes back and he often says that I have not got relief. So then you ask him, okay, what are your symptoms? And you often find that this time the symptoms he is telling are quite different from what he said last time. Which meant that if you gave a medicine which worked for the initial set of symptoms, say for example, that was dysphagia or heartburn, now he might actually come with dyspepsia of the type like, it could be postprandial or whatever, but he confuses it. His unhappiness is of course the same, but the target organ and the symptomatology changes. And this is very important to know that about 30% of patients with any kind of functional bowel disorder would have overlap with another type of functional disorder. So this is very important. So why some physicians are very successful is because when they come back, they listen, they don't react, like I often used to react. So suppose the person had reflux and burning and he came, he said he's not better. So I asked, what's the problem now? And he says, but now I've got bloating. So he forgot that last time it was heartburn. So we often tend to get a bit annoyed and say, but last time you said this, how is that? So he says, I'm better on that, but this is the problem. And we have to make allowance for the fact that we are after all treating the same complex of disorders, no matter where the needle is this time. So this is what I was going to talk a little bit about, GERD and functional dyspepsia. So functional dyspepsia is another term which has now come in, and we distinguished a little bit between what is reflux hypersensitivity, what is refractory GERD, and what is functional dyspepsia. And this umbrella picture more or less tells you the significant degrees of overlap between different types. So don't make a very true to type specific diagnosis. My suggestion would be that, when you start writing your diagnosis, and if there are overlapping symptoms, it's good to start by writing FBD, functional bowel disorder, and then state the other ones, sometimes making or describing the symptoms. Because, next time when he comes, then you haven't committed yourself to a very narrow range and you know what to pursue. Now, there is something about non-cardiac chest pain. What I thought is I'll omit this because this you must have discussed many times in your Tamil Nadu chapter. And I'll go a little bit to another very interesting area. Yeah. So, unfortunately, anything to do with acidity and reflux have in today's time come to mean proton pump inhibitors. I think that the way we write it left and right, fair enough, there are two reasons for it. One is they're the most effective acid suppressants. The number has gone on increasing. They have beaten the others at it. And number two, that over the 30 years now that PPIs have been in the market, there's been a huge amount of pushing by the pharma company and the industry also, as they're struggling to make more and more effective PPIs. Okay, so we know PPIs pretty well. But one of the major things which I want you to know, and this is a very common thing which you must be seeing in your day-to-day practice, you start a person on PPI, he feels better. But he often asks you, how long should I take it? So you give it to him for whatever time, maybe 6 weeks or 12 weeks as you prefer. And then he comes back, and if he tries to stop it, he forgets all the gratitude and he says, but now as soon as I stopped it, it's back again, as though it's your fault. But this is a phenomenon. So there is something called dependence on PPI. I mean, there's another word called addiction, but you may not use the word addiction. It has a different connotation, but dependence. And if you see the prescriptions, the green one indicates refill prescriptions. Whereas this gray, this orange one represents new prescriptions. So if you see, it's the refill prescriptions or continuing prescriptions which is actually becoming taller and taller than the new prescriptions. You see, when you started off with not too much of a difference, but this is what is happening. So one thing that I find in my practice is that a lot of patients, they somehow after a while, they turn a little unhappy and hostile that, okay, but how long do I take it? And why is it not getting cured? Every time I try to stop it, I actually get worse. And often they say, some say it comes back, but many people say that I get worse. So often I used to wonder that how can they get worse? So it must be exaggeration. But this is a study, which is an old study. I'm sure most of you have seen that. See, what happened is, if you look at H. pylori negative people and you look at basal acid output before you have given a PPI, so whatever it was, and then you give a PPI, so what happens is your basal acid output comes down. Okay, no brains, obviously that happens. But when you stop the PPI, then there is something that happens, that your basal acid output actually overshoots what you started off with. So it's not just returning to old, it is actually really something called rebound hyperacidity. There is indeed hyperacidity. And it's not difficult to understand why it is there. That's because when you are suppressing the proton pump, the gastrin levels in the blood keep going up and up and up. So as soon as your proton pump or the final block is lifted, there's a huge amount of pressure on the parietal cells from the gastrin, which causes the acid to really be overproduced and surge. Now, if this happens, and this happens with both H. pylori negative and positive, okay, but with positive may not be that much. We'll come to that sometime later. How do you manage him? He will ask you that, so do I have to continue taking it all my life? And if he's happy and you are also happy, no problem. But if he's unhappy and he wants to stop, then what is a practical way of trying to get these people to stop? So the only practical way is that you have to bring in some kind of a substitute. Because you know that symptom is miserable. I mean, the one where there is burning and pain in the lower esophagus, it's a miserable solution. So many things can be done. One is, of course, you gradually taper your PPI, try to wean it off, substitute it with something like locally acting agents and or with a H2RA. So one of the medicines which is used, I'm sure all of you know, it was in fact launched in Chennai by Dr. Palniswamy and group. This is called calcium alginate. And what is unique about calcium alginate is that, you know, when it comes in contact with water or acid, it forms a foam and it floats above the gastric contents, you know, and the place above the gastric contents is essentially the fundus and the cardia. And interestingly, I have never been able to understand why that acid is almost, I would say, the characteristics should be like water. Why this acid floats up and remains in the upper part of the stomach, whereas the rest of the gastric juice comes towards the lower part. So this is called the acid pocket. I hope all of you know the physiology. So essentially what happens is, here is the scenario. In the postprandial situation, if you have a pH probe in the stomach, postprandial means the part of the acid is neutralized, okay? And then when you are pulling it up, or if you have multiple probes, whichever way you want to do it, you find that the part which is very close to the G junction in the stomach, there is a sharp dip in the pH, which means the acid is right there. And then when it comes up to the esophagus, again, things are a little better. So this is typically what happens when we give PPI or acid suppressants, because whenever there is little acid, it tends to float up and remain just at the cardia and at the fundus. And this is called an acid pocket. And they have done umpteen number of studies using various methods, including the method of tagging the acid with nuclear receptor, tracers, technetium. And they have been able to localize that, yes, it is the acid which is there in the upper part. And this is how it looks like in the CT scan studies, that they're all collecting here, although the food is here. So this is specific to acid. So one of the methods is, of course, to use calcium alginate, because what it does is it tends to go up and occupy the same place and more or less neutralize the acid there. So how do you want to get your patient off of PPI? So this was a question, I'm not posing it to you. This was in another talk. So when 6 weeks or 3 months are over, you say stop when the course is over? Or you say gradually reduce the dose and then stop? Or you say gradually reduce PPI and substitute for some time with an H2RA? Or substitute with a H2RA or an alginate, antacids, lifestyle, whatever you do. So there is no one single answer, but I just want to tell you that A is something where many patients are not comfortable. So if they're not comfortable, don't blame them. I mean, in the sense, you have to understand that we have to do things right again. And this is a process called weaning, where we have to be able to wean them off the PPI. Now I'll come a little bit to this last part of my talk, which I particularly prepared for my colleagues in Tamil Nadu. You know, there are quite a few diseases which we have often thought are lifestyle disorders. And for example, obesity is one, and fatty liver is one, and GERD is one. And although we all know that, yes, lifestyle does make a lot of difference as to what we are eating and whether or not we are doing exercise, the vexing question is that is there a role that genes could also be responsible? So this was a talk I had given long time back, and then, you know, I realized that there were genetic aspects mentioned way back about 10 or 12 years ago. But now I revisited that topic because there has been quite a bit of new development in that area. So one of the problems with what we consider as a multifactorial disease, which is often linked to lifestyle, is to be able to distinguish the role of genes from the role of lifestyle and environment. So this is to talk about obesity, that if you actually try to take a family picture, you'll find that quite a few people seem to share the same phenotype. And the same applies also to GERD. Now, normally, if I were to ask any of my colleagues fellow colleagues in Tamil Nadu, how would you tweak the genetic component over the environmental component if you had to do a thesis or to do a research? So this is how the 4 or 5 steps are, and I thought I'll take you through that. One is, obviously, you start suspecting if there are more patients in a family, so occurrence in families. Just give me a minute, half a minute. So when you have a lot of people having a particular problem in a family, which is a very unique disease, then you know that, okay, it is genetic. For example, if suppose you have a family where there are quite a few people with, say, for example, Marfan syndrome, or if you have people. Okay, somebody is speaking, so anything? Okay. So that is one, but here, you know, okay. Okay. No problem. Somebody is speaking. So one is occurrence in families, but one of the good methods that all of you should know is that there is something called a twin study method, which is a very interesting method, and I thought I'll share this with you. Then there is something called adoption studies. Then, of course, now you have the GWAS, genome-wide association studies, and finally the identification of genes. You know, it's not always so easy. So let me tell you, we are used to thinking that genes means there is one gene or one gene mutation, and it should be very easy to pick up. But sometimes in a complex disorder like, say, obesity or GERD, it may not be one gene and one phenomena. For example, if we're talking about GERD, there could be increased acid production, there could be increased amount of transient lower esophageal sphincter relaxation, there could be increased evidence of hiatus hernia, there could be increased sensitivity in the lower esophagus. Now, you know, each one of them could have certain genetic aspects rather than only one gene which explains a syndrome like GERD. And that's the reason why starting with field studies can be very useful. Sorry. One of you kindly ask the lady to just. Okay, fine. So here I'll tell you. Okay. So the role of genes, as I just mentioned, the role of genes could actually play a role in quite a few things. GERD-based symptoms, esophagitis on endoscopy, development of Barrett's esophagus, and lower esophageal adenocarcinoma, which is a complication of GERD. But when you try to hunt for genes, you can't hunt for one and say that it applies to the other, because GERD is otherwise a very common problem, whereas the other ones tend to become a little rare as we go up the ladder. And in family studies, the confounders are the food, because the family shares the same food, same eating habits, same attitude towards food, same attitudes towards body image, same attitude towards exercise. Environment, attitude I mentioned, and sometimes certain mood changes or states of mind, which can be very important from the point of view of determining acid reflux or acid production. So these are the spectrum, and I'll just go a little quickly into telling you that here, if you look at obesity, yes, there are genes. I think all of you now know it through our NFLD work, and maybe some other time I'll talk about. Metabolic syndrome, we know that now genes are being identified, but remember that never put your money on only one gene. There are going to be many coming. Lower esophageal cancer, there are certain genes or genetic markers which have been identified. Barrett's has been identified. But what about the common reflux? You see, common reflux occurs in roughly about 10 to 15% or 10% of the population. It's not just patients coming to hospital. So it must be extremely common. And then how do you actually find out the genetic part? These are the genetic studies which have been done for the complications of reflux. So Barrett's, for quite a few others, like especially for Barrett's and development of HLA. But if you see under each category, it is not one single gene, but quite a few. And polymorphism is only an issue of statistics as to which of the 4 polymorphs of a particular gene, because you have 2 alleles per chromosome, which of them has a higher frequency. So it is not directly causative. So when we talk about genetics, we are generally used to the family tree concept, where the Mendelian inheritance we understand, like, autosomal dominant, recessive. But, these don't work now, because usually most of the diseases we are talking about now are polygenic, and polygenic plus environment. So doing single, trying to look at single genes like say alkaptonuria and Wilson's and so on and so forth does not apply here. I mean, it's unlikely to be fruitful. People have tried it. So we come to this thing. This is the most important area where we got the lead. It's called twin studies. And in the United States and in Europe, they have something which is called as a twin registry. So there is one Minnesota twin registry, which has got 3,000 twin pairs. And there is another one somewhere else. But essentially what it means is that they have a registry where all twins, monozygotic and dizygotic, are actually kept in a database. And what you do is that when you are trying to study the phenotypic manifestation, like say GERD or fatty liver disease, you have to just pull out the data and ask a questionnaire and try and study whether that phenotype is more common in monozygotic twins versus dizygotic twins. Actually a very interesting concept, because they are twins, but the dizygotic twins have only a 50% sharing of alleles, whereas the monozygotic twin has a larger sharing. And there are quite a few other variables can also be therefore crossed. Now, when they did these studies, this was way back in 2007, and I'll show you some recent data also. You say that, people looked at IBS, GERD, and dyspepsia in twins. And they found, so there were quite a few things, what was common, what was the environment, and so on and so forth. But if you see this carefully, GERD is here in the middle, and the strongest genetic association through monozygotic twin studies was for GERD. There was some which was there for IBS also, but somehow it wasn't there for functional dyspepsia. So this was one of the leads which came way back in 2007, showing that people might have a genetic predisposition. And again, if you see here, the monozygotic twins for GERD was much more than the dizygotic twins. And this is how you actually tend to find out whether there is some role of genes in a very gross method. So this is the recent updated slides which I made. So now this twin studies came in initially around 2002 to 2012 and so on and so forth. Huge number of twin studies, but 3 of them were very popular. 1 done in Mexico, 2 done from the United States. And both somehow came out with the factor that there is a 30 to 31%. So 1/3 of the patients with GERD, the GERD had a heritable factor. So if somebody says that, look, it runs in the family, mother also had it, well, it could be food, but also keep in mind that heritability factor is also 1/3. Now we go a little bit to more complex issues with genes, because this is for the students, DNB and DM students. So people have now therefore tried to go further into genetic loci, with genes and genetic loci and so on and so forth. So one article which came out in 2011 from Dr. Ghoshal's group, so they found that it's certainly not an easy chapter, because there were at least more than 10 genes which were involved. So it can't be one gene, okay? Because these are some of the genetic markers where they studied the polymorphism, and also they had to see the environmental factor of H. pylori, because presence of H. pylori actually reduced the chances of GERD. Okay? So genetic studies, I mean, what I want to tell you is doing GWAS or trying to find out gene mapping studies doesn't always apply. Sometimes a broader based common sense approach, like trying to find the concurrence rate in monozygotic versus dizygotic twins approach, has a better yield. So now I just want my young fellows to understand why the situation is complex. We know that there is a 30 to 31% heritability. But beyond that, if you look at it, these are the factors which can contribute to GERD or its complications. Okay? So there is an inflammatory response, there is a cell cycle regulation response. This is the one which is important for healing of the erosions. There's a DNA repair mechanism approach, which is important for development of esophageal adenocarcinoma. There is an esophageal sensory function, very important for the perception of GERD, because much of the symptoms that you do by questionnaire is based on symptoms. And of course, T cell regulation. And I have indicated to you that there are susceptible risk genes for GERD in all these 5 domains, which can account for GERD when you actually just do a, shall we say, a field study or a questionnaire-based study on GERD. So you see, the amount of genetic variations can be immense, and therefore to tweak it out can be very, very difficult. So now, but the laboratory people are also still very active. So as you know, with COVID now, people are now trying to find out different strains. Some are more virulent, some are less. Whereas the more practical people are saying, come what may, wear your mask and so on and so forth, whatever. So here, let's go a little bit deeper into what have been studied. And these are all recent studies. So the genetic risk loci associated with development of GERD, there has been something called single nucleotide polymorphism studies. These are very easy to do. So I think when I was at Lucknow, we did quite a few SNPs, SNPs as we call it, studies in a wide variety of disorders, including alcoholic liver disease and all that. But here, if you look at SNPs, they have been able to identify, mainly statistically, in chromosome 19, chromosome 3, chromosome 15, and in the PRRXI gene. Okay. And remember that there is another part to it. This is GERD in terms of the damage produced. But what about the GERD in terms of the acid part of it and mucosal injury? So there is an ion channel and cell adhesion regulator part of it. And here again, there are 9 loci. So there are quite a few here. 1, 2, 3, 4, and 9. So quite a few loci that actually govern the genetic part, or that is the 30% heritability that we seem to have. So be careful. I think genetic aspects of GERD or functional bowel disorder, or if somebody wants to trap you for dyspepsia, could be a very important short note question. And I don't really expect you to remember the numbers, but I want you to remember the principles. And the principles are the ones which I started. First, the observation of increased frequency in families. From families, take it down to looking at twin studies. In twins, look at monozygotic versus dizygotic. See the concordance levels. Then move a little bit more towards identification of genes or loci through different pathways. So polymorphism, SNPs, and so on and so forth, before you can think about coming to genes. But the gene story is complicated because there are so many genes and so many loci, you can't actually give a very simple answer. So with that, I just thought I'll conclude by telling you that genetics is actually beginning to play a role in quite a few so-called lifestyle disorders also, or environmental disorders, because how we respond to the environment depends on how the genes have been, how our genetic part is loaded, genetics is loaded. And this is a very important part you must know. So genetics loads the gun, but the environment pulls the trigger. So remember that everything which we think is environmental could also have a genetic basis. On the other extreme, you have got pure genetic diseases like, say, retinoblastoma and Wilson's disease and alkaptonuria, where it is a very simple story about a single chromosome and a single gene. So this is the way the complexity is going. Thank you very much for your patient hearing.
Thank you. Thank you. Thank you.
Thank you, sir. Now the field is open for questions. We have 20 minutes, 15 minutes for question answers, please. Madam, you want to?
Yeah, I just try to make it brief to give you some insights as to where all you should be reading, the new events which are occurring.
There are a lot of questions in the chat box. You can just take up the lead.
Or you want me to take it from the chat box? Okay.
Questions in the chat box, sir.
Okay. Yeah, there are 8 of them. Okay. Okay. So there is one very interesting question. This is from Dr. Ankit Patel, that sometimes now when we give PPI, initially they respond, but then when after some time either they don't respond or they require, they are frustrated every time we stop. So should we then offer fundoplication, or should I treat with high dose of PPI? Very, very important question. Very important question. I'll just come back to that because I had 3 slides, but I actually didn't discuss that point, but I think that there's a very important point to be made. Yeah. Any information of these, Dr. Jayanti has asked to everyone, any information of these genes in the general population, or they are specific for GERD? So Anybody would like to try that answering this one, or should I answer first? Very, very good question. It actually tests your understanding, the conceptual understanding of the whole thing. Anybody wants to volunteer a guess? No? Let me try to see if I have that slide for the no, I don't, but I'll come back to it, no problem. Jayanti, if you can keep asking, I'll follow up on that. I'll just open that other slide of mine, because that's again something conceptually, it's a very important question somebody has asked.
There are some questions on how to wean off these patients in GR. Do we give an intermittent treatment, or treatment once in 3 days as a weaning concept, or we go on a low dose? So these questions keep coming.
Okay, very good. So let me, I've done this as GERD Tamil Nadu. I don't know how I, okay. I'll first take this question about surgery, and I want people to understand why. The why is more important than what.
I feel lifestyle is one of the major components in management of these patients. We spend some time for them to reduce the body weight. Nowadays, with COVID and all, people are taking a lot of ginger and garlic, so it's likely to increase the GER. So I think lifestyle.
How do you people like ginger and garlic? I mean, is it?
That's one of the treatment that most of the people take here, with a little bit of turmeric, some honey, and all types of combination as immunogenic.
Are you on the screen share, or I've lost that?
We are okay. We are okay.
You can see the slide.
You can see the slide.
Okay. So I'm just reversing the sequence. The first question is that how to stop it. So, you know, if the course of PPI has been short, and if the person has worked hard in trying to modify his diet and lifestyle, you can stop the course, you know, if it's a 6-week course or a 4-week course, and, you know, the person can be fine. The longer is the duration of treatment, it becomes more difficult to wean the person off. Okay. So why it is important is because earlier on people thought that PPIs are very safe, so you can go on giving it for years. There's been a plethora of articles highlighting the side effects or adverse effects. So all the international PPI majors have revised their criteria that for symptomatic patients based on symptoms, when you start, your initial treatment should not exceed 6 weeks. Earlier on, they used to say 12 weeks or so on and so forth. They have actually reduced it, okay? Don't confuse it. The treatment duration is still 3 months or 12 weeks if you have a proven ulcer, or if you have a significant amount of reflux with dysplasia, with Barrett's or whatever. I'm talking about empirical therapy. So empirical therapy, the guidelines have now been reduced to 6 weeks. And this is obviously because of an alert that has been sounded. So if you give a short course initially, try to wean them off, it's fine. If you find that the person, whenever he's trying to stop, then he's getting into trouble, then all these 3 options are fine. So one of you mentioned reducing the dose, absolutely right. So from 40 milligram to 20 milligram, then you make it 20 milligram alternate day, and then, you know, see twice a week and come out. If you find that the person is still not able to come off, but the person is saying that, look, it's almost like I'm hooked and all, then what I usually do, I substitute a H2RA. So quite a few of my patients were on ranitidine, but, you know, ever since the scare about ranitidine causing gastric cancer, so and it came out in the press, you know, public press. So about at least 100 patients called me that, you know, it's carcinogenic. So there's no point in arguing whatever the facts may be. So I usually switch to famotidine, which is very, very cheap, but it's hardly available. It's 50 paisa a tablet. I find it extremely useful. Incidentally, for those who are a little swanky, westernized, if you tell them that the acid suppressant which is available in the United States in departmental stores, it's actually, by the way, famotidine. It comes by the name of Pepsid. And of course, Nexium is also available, but Pepsid is. So that gives it a sense of safety and sanctity that, look, it's available in US in departmental stores. So it must be safe. The other option is I often bank quite a bit on alginate or antacids. Sometimes I have found that many people are not very happy with one product or the other. So I ask them to do what is known as a on-demand therapy of trying to manage their symptoms. The other part which Jayanti mentioned, I can't overemphasize. I usually tell them that, look, during this period of 6 weeks to 12 weeks or whatever, this is an investment time for you. And you have to turn all your things upside down in terms of environmental triggers. So, you know, in the north, the problem is many people are overweight. They take a late dinner. The dinner has a lot of fry in it, you know, I mean, butter chicken and stuff like that, with a lot of spices. And often they have alcohol with it. And if they smoke, then it's even worse, because all these worsen reflux. So if you now tell anybody to be a good boy, they don't like it. Everybody wants to be the bad boy. So you have to basically work your way to trying to get them to change the main triggers and how to modify it. And I think an early dinner, avoiding the 5 foods which worsen reflux, that's, you know, fat, chocolates, aerated drinks, excess of tea, coffee, and certain pungent spices. They are the ones which lower the lower esophageal sphincter pressure and increase TSLER. So those are the ones which I recommend that they should avoid. And in case if they're a bit overweight, I actually encourage people to do intermittent fasting. And, you know, if they reduce their eating of the dinner, they're usually much better off. But anyway, that's their call. So working on lifestyle, I think it can't be overemphasized. Jayanti, thanks for that. And weight reduction is a longish process, but, you know, they have to be at it, and that's how to go about it. With regard to surgery, I think this question that was asked, very important question. You know, one of the common pitfalls is that we give PPI, the response is not very good, so the patient is unhappy. He says it's not been working too well. So then in disgust, we say that, okay, go to the surgeon and he'll get a fundoplication done. That is actually the patient whom not to send for surgery. And this is extremely important. Of course, the surgery that is done is now become simple. It's a laparoscopic fundoplication, and there are different types of wraps. So 270, 360, you know, how they do it and so on and so forth. But essentially, it's the same thing, that you are pulling it down. So if there is a bit of a hiatus, it comes down, and then you put a wrap so that it doesn't go up, and you have tightened the sphincter. So here is a question for you. Whom would you recommend fundoplication surgery? Inadequate heartburn symptom response to PPI, good response to PPI, relapses on stopping each time, and not willing to take medications for life, GERD with early Barrett's esophagus with mild dysplasia, and GERD with troublesome water brash and coughing. So which are the ones which you would recommend surgery for? Any idea? Any?
Ankit, you can answer that question.
Whom have you asked?
Dr. Ankit?
Yeah, please.
Dr. Ankit, you're online. I think probably asked the question, he's left, I think. I don't know.
Okay. So let me give you my inputs to you. The first one, A, inadequate heartburn symptom response to PPI. Certainly not a good candidate for surgery. Okay, because there is a doubt that whether this person indeed truly has reflux causing the symptoms. Because if you have reflux causing the symptoms, I told you the PPI test, even if it is 2/3 positive, it's got a very good sensitivity and specificity. So if it is that category, then doing a surgery helps. This A is a bad candidate, and they'll be always frustrated, first with the surgeon, then they'll come back to you. B is the right response, that is good response to PPI, but each time they stop, it relapses and he is very frustrated. He is not doing well on antacids and H2RAs. He loves his PPI, but he says, I can't go on doing it for the next 30 years. He's a good candidate, but you must mentally prepare him that he may still require some degree of acid suppression post-surgery, but the amount may come down. And it usually does. The third one, C, just watch. These questions are I drafted it with a lot of care. GERD with early Barrett's esophagus with mild dysplasia. Would you or would you recommend surgery? The answer is no. Because you see, in this fundoplication surgery, you are actually not treating the Barrett's. You are actually treating only the reflux. Okay? And in mild Barrett's esophagus with mild dysplasia, there is really no role for doing an esophageal resection also, removing that segment. So that is actually, again, not a very good choice for getting for a fundoplication surgery. Obviously, if the Barrett's becomes a very aggressive Barrett's with high-grade dysplasia, then it's an indication for surgery. But again, it's not a fundoplication surgery. It's a different surgery. Okay? And the last one is also a right one. If there is GERD with troublesome water brush and coughing, which is basically a volume refluxer, often occurring at night, they actually benefit from fundoplication. So if suppose they want to take a chance and get it done, that's a largely mechanical issue, and I think they get good relief. So A and D are actually good choices, I would say. So this is the two slides that I want to show you. If you look at patients who have been randomized to surgery and randomized to medication, the response has been similar. The only difference is that you don't have to keep popping pills. And here, if you see the percentage taking anti-reflux drugs, the ones who have undergone surgery, there the requirement of medicines have come down. So that is the primary benefit for which you are recommended. So many good surgeons actually want the gastroenterologist to document a good PPI response before they offer surgery. Okay. And any other questions? Sorry, Jayanti, you are a big help. Any other questions?
The genetic bit in the general population, I had asked.
Yeah, you asked. So, if you look at individual loci, they would be present in a whole lot of population studies. The reason is, many of them are actually polymorphism studies. So polymorphism studies, you have done quite a bit, Jayanti, so did we on gallbladder and all. So polymorphism study is not a causal study that, one particular gene loci causing a mutation is the cause of one problem. It's only statistics that if there are 4 variants, then which one is a little more in which group. So having said that, it's almost like the same story, that which blood group is more prone to causing, to getting COVID infections and the COVID infection turning severe. So although it may be A+, it doesn't mean that only A+ people will have the problem and others won't. So this is purely statistical. So the prevalence of those loci and those genes are likely to be in quite a large number of people. And these are combinations which set a pattern. So that has to be understood. So that's why I think from the point of view of routine diagnostics, as of now, there is no role for doing genetic studies for GERD. It is only to enhance our own understanding as to how things are.
Very much, Dr. GC. Dr. Malti, can you give your concluding remarks?
I think it was an excellent lecture, and I think it was good that you brought out the genes. I think next time when we talk, we'll be talking about gene in GRD, and that will be the way forward, how we are going to identify, because there are some who do not respond and they will have it running in families. So maybe other forms of therapy. But for the time being, I think, like you all said, lifestyle modifications. And nicely you have said not to stop the medication, but to wean it off rather than going together, and the various reasons for the refractory GRD. Thank you, Dr. Gourdas, for giving us this time and spending time with us and teaching us the basics, but which we are not very clear about in GRD. Thank you, Jayanti. Thank you, everyone, for listening. Thank you, Val, for arranging this meeting.
It was a pleasure to interact with my old friends, and Jayanti, Malti, I can see so many, Ubal and Palniswamy, so it's always good to connect with you people.
So on that note, I'm afraid we are run out of time, sir. Thank you so much for being. Thanks, everyone.
Thank you.
And
Sir.
Dr. GC, vanakkam.
Bye. Thanks. Vanakkam.